Chapter 12 Schizophrenia Spectrum Disorders. Schizophrenia spectrum disorders share features with schizophrenia and are characterized by psychosis, confusion, altered cognition, altered perception, and/or impaired ability to determine what is real or not. First up is delusional disorder, and this involves false thoughts or beliefs that have lasted for 1 month or longer. And these delusions can take a lot of forms. Everything from grandiose thinking, thinking that they're the senator, thinking that they're famous, to persecutory delusions, thinking that everyone is out to get them, and may even include somatic delusions. They have a slight headache and now they're convinced that they have a brain tumor. Unfortunately, these are not severe enough to impair their functioning. Next would be brief psychotic disorder, and this would involve a sudden onset of at least one or more of the following: delusions, hallucinations, disorganized speech, and disorganized or catatonic behavior. And the duration must last much longer than 1 day, but not longer than 1 month, with the expectation of a return to normal functioning. Not to be confused with schizophreniform disorder. In this case, the symptoms are exactly like those of schizophrenia, except the symptoms have lasted less than 6 months. It may also be characterized by social or occupational functioning that could be apparent or not, and may or may not return to their previous level of functioning eventually. Next up would be schizoaffective disorder, and this would involve major depression, manic or mixed episodes, running concurrent with symptoms that meet the criteria for schizophrenia. And also keep in mind, this would not be caused by any substance use or general medical condition. This is a schizoaffective disorder with no underlying apparent causes. Was there substance abuse or an underlying medical condition, it would then be categorized as substance-induced psychotic disorder and psychotic disorder due to another medical condition. And again, this would involve those delusions or hallucinations secondary to illicit drug use, alcohol, medication, or other toxins. It could also be delusions or hallucinations resulting from delirium, neurological disease, hepatic or renal disease, and many, many other causes. Which brings us all to schizophrenia, a term we've all heard of. It's a very sad condition affecting up to 1% of the population. It's characterized by psychosis, altered cognition, perception, and reality testing. 75% of these cases develop gradually, presenting at 15 to 25 years of age. The child onset and late onset are much, much more rare. To meet the DSM-5 criteria, there must be 2 or more of the following for a significant portion of time within 1 month. These would include things like delusions, hallucinations, disorganized speech, gross disorganized or catatonia, negative symptoms such as diminished emotionless expression, functional impairment of some kind, continuous disturbance for at least 6 months. And again, if there is a history of autism spectrum disorder or a communication disorder of childhood onset, the additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations are in addition to the other required symptoms of schizophrenia. For our first case study, Eric M., 18, has always been a good student. However, his second semester of college, he begins for the first time in his life to have trouble concentrating. When his family doesn't hear from Eric, they contact the school, only to discover that his roommate says Eric is talking weird. Asked what he means, the roommate says, well, he says stuff that doesn't connect, doesn't make any sense. Asked him if he was high or something, but he said no, and I believed him. On further investigation, Eric's professors say he's been missing class after starting out so well. Eric's roommate says his speech doesn't connect. It doesn't make any sense. He sort of gets derailed. Which of the following symptoms is Eric displaying? Would that be A, avolitional speech, B, delusional speech, C, disorganized speech, or D, diminished emotional expression? And that answer is C, disorganized speech. It's characterized by frequent derailment or incoherence. It's not necessarily always a negative symptom that's characterized by diminished emotional expression, nor is it necessarily delusional. Childhood onset of schizophrenia occurs in 1 in 40,000 children, and there has no differences related to race or culture. It affects everyone, though is more frequently diagnosed among males and in urban areas. There are many comorbidities that can go along with schizophrenia, such as substance abuse disorders, nicotine dependence, and in this case they are trying to self-medicate themselves because they know something is wrong. It could also go alongside anxiety, depression, and suicide, other physical illnesses, and polydipsia. Schizophrenia has a major genetic factor in that it tends to run in families, also involving brain structural abnormalities, prenatal stressors, and environmental factors. There are four phases of schizophrenia, first being the prodromal stage, which is occurring before the acute symptoms of schizophrenia occur. These people may experience mild changes in thinking, reality testing, and mood. Speech and thoughts may be odd and anxiety, with obsessive thoughts and compulsive behaviors. Following that is that acute manifestation of symptoms, following by stabilization and maintenance or residual symptoms. Eric's parents arrive on campus, and he agrees to meet with them and a campus counselor. He appears anxious. He expresses sorrow that his grades are suffering, acknowledging that his concentration just isn't there. He says that he feels something weird is happening to him, and describes frequent distressing thoughts. He admits to feeling suspicious of everyone he passes. Eric's parents and the counselor both notice what the roommate had described about Eric's speech. Moving through these stages with that prodromal, that's onset with mild changes, followed by acute, which is exacerbation of symptoms. Moving into stabilization, meaning the symptoms are diminishing, with a movement towards that previous level of functioning, and a maintenance, with a new baseline established. In this case, our case study, it sounds like Eric is going from that prodromal possibly into acute manifestations. Eric agrees to see a psychiatrist, and an initial assessment and history indicate that he has only been experiencing some mild changes in his thinking and mood for about a month. Ever since returning from the winter holiday, the examiner confirms that his speech is sometimes disorganized, and his ability to concentrate and study is diminished from his previous long standing as a strong student. Given the evidence we have so far, if Eric has schizophrenia, which is suspected, which phase is he most likely experiencing? Would that be A, acute, B, residual, C, prodromal, or D, stabilization? In this case, the prodromal stage is characterized by mild changes in thinking, reality testing, and mood, and is insufficient to meet the diagnostic criteria for schizophrenia. During our assessment, we should especially be focused on both positive and negative symptoms. In this case, a positive symptom is the presence of symptoms that should not be present, such as hallucinations, delusions, paranoia, or disorganized or bizarre thoughts, behaviors, or speech. Not to be confused with those negative symptoms, and this means the absence of qualities that should be present. Negative symptoms include the inability to enjoy activities, anhedonia, social discomfort, or a lack of goal-directed behavior. There could also be cognitive symptoms, such as subtle or obvious impairment of memory, attention, thinking. And affective symptoms. These are symptoms involving emotions and their expression. Positive symptoms involve alterations in reality testing. These delusions, both false, fixed beliefs, alterations in speech, and concrete thinking, meaning an inability to think abstractly. Alterations in speech may also be present, including things like associative looseness, in some cases even word salad, which is the most extreme form, involving a jumble of words meaningless to the normal listener. Other things like clang association, meaning words are chosen based on sound or rhyming. Neologisms, which are meaningless words that have meaning only for that patient. And echolalia, which is them repeating your words back to you, echoing their words back to you. Other abnormal speech patterns would be things like circumstantiality, meaning they're including unnecessary and often tedious details in conversation, but without really eventually reaching that point. Other things like tangentiality, wandering off topic or going off on tangents and never reaching the point. Cognitive retardation, which means generalized slowing of thinking, which is represented by delays in responding to questions or difficulty finishing thoughts. Pressured speech, which is an urgent or intense and resist comments from others. Flight of ideas, meaning they move rapidly from one thought to the next, often making it difficult for others to follow the conversation. And symbolic speech, using symbols instead of direct communication. For example, a patient reports demons are sticking needles in me, when what he means is that he's experiencing a sharp pain. Disorders or distortions of thought may also be present. Things like thought blocking, a reduction or stoppage of thought, interruption of thoughts by hallucinations, can cause this. Thought insertion, the uncomfortable belief that someone has inserted thoughts into their brain. Thought deletion, a belief that thoughts have been taken out or are missing. magical thinking, believing that their thoughts or actions affect other consequences. And finally, paranoia, an irrational fear ranging from mild, wary, guarded, to profound, believing irrationally that another person intends to kill you. During an assessment, Eric has trouble staying on topic, zipping rapidly from one thought to the next, making it hard to follow what he's trying to say. Which speech disturbance is he exhibiting? Would that be A, pressured speech, B, circumstantiality, C, flight of ideas, or D, tangentiality? And in this case, that is C, flight of ideas, meaning he's moving rapidly from one thought to the next, often making it difficult for people to understand what he's trying to get across. Alterations in perception and hallucinations may also be present. And these hallucinations can take a lot of different forms, everything from auditory, visual, olfactory, gustatory, tactile, or command hallucinations. There could also be illusions, depersonalization, and derealization as well. And alterations in behavior could be present, such as catatonia or a catatonic demeanor, echopraxia, meaning the mimicking of movements of another, stereotype behaviors, the repetitive behaviors that do not serve a logical purpose, gesturing or posturing, assuming an unusual or illogical expression, often grimaces, and boundary impairment, an impaired ability to sense when one's body or influence ends and another's begins. Negative symptoms could be another aspect of the condition. Everything from anhedonia, meaning that reduced ability or inability to experience pleasure in everyday life. Avolition, that loss of motivation or difficulty beginning and sustaining goals. Asociality, and that's that decreased desire for or comfort during social interaction. Affective blunting, reduced or constricted affect. Apathy, a decreased interest in or attention to activities or beliefs that would otherwise be interesting or important. And alogia, that means a reduction in speech, sometimes called poverty of speech. You're going to hear the term affect a lot throughout mental health. And by affect, we mean that outward expression of a person's internal emotional state. It could be everything from flat, meaning immobile or blank facial expression, blunted, meaning a reduced or minimal emotional response, constricted, which is a reduced emotional response that is reduced in range or intensity, and inappropriate, such as incongruent with the actual emotional state of the situation. And finally, bizarre. These are odd, illogical, inappropriate, or unfounded actions or symptoms. For cognitive symptoms, we may see things like concrete thinking, meaning an impaired ability to think abstractly, resulting in interpreting or perceiving things in their literal manner. Difficulty responding to concepts like love or humor. There could be impaired memory, which impacts both the short-term memory and their ability to learn. Impaired information processing, which would involve delayed responses, misperceptions, or difficulty understanding others. Impaired executive functioning, meaning that difficulty with reasoning, setting priorities, comparing options, and placing things in logical order or groups. And finally, anosognosia, an inability to realize one is ill caused by the illness itself. Anosognosia. Assessment of depression is also going to be crucial and may herald impending relapse. Increases in substance abuse, increases in suicidal risk, and further impairs in functioning may also be major indicators. That anosognosia can be a major impediment to helping the patient realize that these hallucinations are not there, that they need to be able to realize that they are ill. This anosognosia could be caused by the illness itself and may result in a resistance to or cessation of treatment, often combined with a paranoia so that accepting help is often impossible. Eric becomes anxious and says, "There are worms under my skin eating the hair follicles." How would you classify this assessment finding? Would that be A, positive symptoms, B, negative symptoms, C, cognitive symptoms, or D, depressive symptoms? In this case, this is definitely A, positive symptoms, as in the presence of something that should not be present. Under assessment guidelines, we should include any medical problems that may mimic psychosis, drug or alcohol use disorders, mental status examinations, and also include that cognitive assessment, including things like reality testing. We should also be assessing for hallucinations, delusions. Their suicide risk is going to be a major priority with these patients. Also, their ability to ensure personal safety and health, assess any prescribed meds they're taking, the symptoms' impact on their functioning, and the family's knowledge of their condition. The psychiatric nurse conducting Eric's assessment believed that he's also suffering from command hallucinations. To assess this, you should be asking things like, do you recognize the voices? Do you believe the voices are real? And do you plan to follow any of their commands? There's going to be a wide range of nursing diagnoses we could include with this patient's plan of care, including things like hallucinations, delusions, risk for violence, distorted thinking, impaired abstract thinking, impaired communication, anosognosia, negative self-image, risk for loneliness, powerlessness, risk for suicide, and impaired health maintenance, among a wide range of others. When identifying outcomes, under that acute phase, we need to be prioritizing patient safety and medical stabilization. Stabilization would involve helping the patient understand the illness and treatment, stabilize their medications, and control or cope with their symptoms. And then finally, maintain this achievement, help to prevent relapse, and achieve independence and a satisfactory quality of life. After an acute admission, discharge is being planned for Eric. What are some things that need to be considered? And some of these things are external factors, such as the patient's living arrangement, economic resources, financial supports, and family relationships. They could go along with internal factors such as resilience and coping skills. For planning, within the acute phase, we need to be identifying strategies to ensure patient safety and provide symptom stabilization. And then finally, in the maintenance stage, we need to be providing the patient and family with education so that they know what they know about the condition, they know the risks, they know the dangers, and they also know strategies for helping to manage it. We're going to have a wide range of interventions from psychiatric, mental, and neurological evaluations, psychopharmacologic treatment, support, psychoeducation, monitoring fluid intake, and working with aggression. Unfortunately, working with aggression is going to be a key skill for your time as a mental health nurse. Aggression may stem from the paranoia, command hallucinations, conflicts with staff about the treatment or limit setting, and conflicts with peers as well. Stabilization and maintenance phases, we're going to be focusing on medication administration, making sure the patient is adherent to their medications, working with their relationships with their providers, building up that rapport, building up and working on teamwork and safety and activities in groups. There's going to be a lot of group therapy that goes along with their individualized treatment and therapy within the inpatient setting. Assessing for paranoid thoughts, command hallucinations, interpersonal conflict, irritability, impaired impulse control, increasing tension and desperation, among a wide range of other things, is going to take a lot of work. We want to be focusing on these hallucinations, these delusions, and these associative looseness, and other symptoms that go along with schizophrenia and make it so difficult to treat. We want to reevaluate the patient's progress regularly and adjust the treatment when needed. Even after symptoms improve outwardly, inside the patient is still recovering. We want to set small goals, as recovery from this condition can take months, and also involve active, ongoing communication and caring, building up that therapeutic relationship and that rapport with the patient. Let's get into treatment modalities. First, let's talk about antipsychotic medications. I know we've talked a bit about those first generation antipsychotics like Haldol and second generations like Zyprexa and olanzapine. And there's going to be so many different antipsychotic medications. I plan for one of our tutoring days. I've got a great Kahoot material together on pharmacology, which I think will help us both for this class as well as med-surg. First-generation antipsychotics are classified as dopamine antagonists and target the positive symptoms of schizophrenia. They have a lot of benefits, such as they're less expensive than second generations, and they are very, very effective. Unfortunately, they also go along with a lot of adverse effects, such as extrapyramidal symptoms, anticholinergic side effects, and that tardive dyskinesia. Second-generation antipsychotics, on the other hand, involve both serotonin and dopamine antagonists, and they treat both the positive and negative symptoms with minimal to no extrapyramidal symptoms or tardive dyskinesia. Unfortunately, they tend to cause significant weight gain and risk of metabolic syndrome. And finally, these newest generation, the third generation antipsychotics. These are drugs such as Abilify, which you'll see more and more out there. And they may improve positive and negative symptoms and cognitive functioning, with little risk of the extrapyramidal symptoms or tardive dyskinesia, especially associated with first generation. We want to be very careful when administering all antipsychotic medication, especially with those first generation. These can have a dangerous side effect known as anticholinergic toxicity. This would be characterized by reduced or absent peristalsis, leading to a bowel obstruction, urinary retention, mydriasis, hyperpyrexia with or without diaphoresis, hot dry skin, delirium with tachycardia, unstable vital signs, agitation, disorientation, hallucinations, or reduced responsiveness. Another dangerous adverse effect would be neuroleptic malignant syndrome, characterized by severe muscle rigidity, flexor extensor posturing, reduced or absent speech and movement, decreased responsiveness, and again that hyperpyrexia, characterized by a temperature over 103 degrees Fahrenheit. Severe neutropenia may also be present, including a reduced neutrophil count and increased frequency and severity of infections. Any symptoms suggesting infection should be taken very seriously for patients on antipsychotics. Less severe, though definitely something to be aware of, would be metabolic syndrome. And this is characterized by weight gain, especially in the abdomen, dyslipidemia, increased blood glucose, and insulin resistance. These increases the risk of diabetes, certain cancers, hypertension, and cardiovascular disease. For cardiac issues, be looking very carefully at that prolonged QT interval. This involves a delay of the ventricular repolarization and may result in tachycardia, fainting, seizures, or even sudden death. Liver failure may also be present, involving an impairment usually occurs in the first weeks of the therapy. Symptoms would be things like jaundice, abdominal pain, ascites, vomiting, lower extremity edema, dark urine, or a pale or tar-colored stools. Extrapyramidal symptoms are a blanket term covering things like acute dystonia, or a sudden sustained contraction, akathisia, that motor restlessness causing inability to stay still or remain in one place, pseudo-Parkinsonianism, which would be symptoms mimicking Parkinson's disease, and that tardive dyskinesia, involuntarily rhythmic movements of the face and tongue. As a student once told me they always remembered it by the tartar sauce on your lips. There will be a wide range of psychological therapies that go along with their treatment, including things like individual and group therapy, psychoeducation, medication prescription and monitoring, basic health assessments, family therapy, and support groups. Loose associations in a person with schizophrenia indicate A. Paranoia, B. Mood instability, C. Depersonalization, or D. Poorly organized thinking. That answer is going to be D. Poorly organized thinking. And for our final question of this chapter, which assessment finding represents a negative symptom of schizophrenia? Would that be A. Apathy, B. Delusion, C. Motor tic, or D. Hallucinations? And that answer, again, is going to be A. Apathy, because that is a lack of something that should be there that isn't. In case of delusions, motor tics, and hallucinations, those are positive symptoms because they are there when they should not be. And anyway, that's all we've got in this chapter. I'll see you in the next slides.